MedCram.com.
Welcome to another MedCram COVID-19 update. Today we're going to talk about this vitamin D paradox. Why is it that low levels of vitamin D are associated with severe COVID-19, but when we prospectively supplement with vitamin D, we don't improve COVID-19 severity? So here's a paper that was recently published, peer-reviewed, in fact, 1,176 patients admitted to the hospital. And what they found was that patients with less than 20 nanograms per milliliter of vitamin D were 14 times more likely to have severe or critical disease compared to patients who had vitamin D levels that were greater than 40 nanograms per milliliter. So the conclusions of this paper was among hospitalized patients, COVID-19 patients, pre-infection deficiency of vitamin D was associated with increased disease severity and mortality. Pretty clear. And this goes back quite a long way. This is a paper that was published in September of 2020. And what did they find? They showed here that inpatient survival with respect to vitamin D was greatly dependent on the vitamin D levels. Here you can see the survival probability was significantly lower if vitamin D levels were less than 12 nanograms per milliliter compared to those that were above 12 nanograms per milliliter. That's pretty low. And even if we raised it to 20, there was still a statistically significant difference. So these studies should not be new to you. We've talked about this before extensively. This was a video that we did a year ago, which got over 12 million views, where we reviewed all of this data, showing clearly that low vitamin D levels were associated with more severe outcomes. But here's a paper that was just recently put on Medical Archives, has not been peer-reviewed as yet. And this was done by a group that is really interested in showing that vitamin D works. Adrian Martineau is the author that published the 2017 British Medical Journal article that showed a meta-analysis showing that vitamin D cut the risk of acute respiratory infection. So this is not done by a group who wants to disprove vitamin D. They want vitamin D to work. And they've done a good randomized controlled trial here, where they looked at 6,200 patients and they gave a dose, not a small dose, not a very large dose, but 3,200 international units of vitamin D. And what did it show? This is a randomized controlled trial. It says, in conclusion, we report that implementation of a test and treat approach to correcting suboptimal vitamin D status in the UK population was safe and effective in boosting 25-hydroxy vitamin D concentrations of adults with baseline concentrations less than 75 nanomoles per liter. Now, just so you're aware, let's stop right there. 75 nanomoles per liter is equivalent to 30 nanograms per milliliter. So just make sure, unfortunately, we have two different scales here, but that would be equivalent to 30. So when they had it less than 30, they supplemented them. Here's the key statement. However, this was not associated with protection against all-cause acute respiratory infections or COVID-19. Now, I'm not going to go over the data because that's not the point of this video. The point of this video is to say that there are numerous studies out there which, for whatever reason, aren't showing much in terms of moving the needle when giving vitamin D prospectively. There are some studies that seem to indicate some promise. And look, I'm not against vitamin D. I take my vitamin D supplement every day. We recently just published a video here on MedCram that showed that all autoimmune diseases reduced in incidence when vitamin D was given prospectively over a 5-year period of time. So I definitely believe vitamin D supplementation has its place. But there's still a paradox here. It's almost without exception that we are seeing association studies showing that vitamin D levels that are low are associated with severe COVID-19. But we're not seeing the data on prospectively supplementing with vitamin D, reducing severity of COVID-19. And for those of you that have watched our video, Light as Medicine, vitamin D isn't enough. This should not come as a surprise to you. But I'm still seeing people out there that are scratching their heads. And so I needed to make this more clear about what I believe is going on here. And to basically give you the understanding here, those people that tend to be outside and in sunlight, maybe even indirect sunlight, even though they're wearing clothing, they're being shielded from the sunlight, there's still near infrared radiation that can get through. What we're seeing here is an increase in ultraviolet radiation because they're outside. And in general, they're going to have increased vitamin D levels because ultraviolet light makes vitamin D. But because both near-infrared radiation and ultraviolet radiation come from the same place, They're also going to have an increase in near-infrared radiation, and that, as we talk about in that video, and we'll talk about here later, increases intracellular melatonin. My understanding of this is that intracellular melatonin is really what we need to have less severe COVID-19. Those people that tend to stay inside, these are people typically who live in more modern environments, people who live in more industrialized countries, people who have means and affluence, who go to work in their cars, stay in their homes, and go to work and stay in their offices rather than working outside. They will have both less ultraviolet light and less near-infrared radiation. As a result of that, they will have less vitamin D and less intracellular melatonin, which means they're going to have more severe COVID-19. For instance, at some point here during the pandemic, the United States represents 4% of the population of the world, and yet it had 25% of the cases of COVID-19. So if you look at this dichotomy, those who tend to be outside and those who tend to be inside, if it's really intracellular melatonin which is doing the heavy lifting, you can imagine that supplementing with vitamin D in someone who has low vitamin D levels may not be the solution to reducing more severe COVID-19 because it's not the thing that's doing the heavy lifting. Let's explain a little bit more. So it's no surprise that there is an influenza season. And as you can see here from the real data in the United States in terms of flu deaths, this happens towards the beginning and the end of the year. We specifically have a period from about October to about March or April, where every year, regardless of what's happening, we have the same number of predictable deaths in the United States. Now, why is that? Well, it could be because of temperature. It gets cold in the wintertime. It could be because of a change in humidity. That changes in the wintertime. Or it could be because of the fact that we're getting less sunlight. Less sunlight because, at least in the northern hemisphere, the sun is going towards the south, and as a result of that, we're not getting as much sunlight. And of course, we know that when we look at all of the energy that's coming from the sun, the solar radiation spectrum, we have a particular area here, which is bounded by these two red lines, which is the visible spectrum. That's red, orange, yellow, green, blue, and violet. However, past violet is the ultraviolet spectrum, and we know that ultraviolet radiation makes vitamin D. So maybe it's the vitamin D that's helping us out, and that's the reason why we're not getting influenza. At least that's the theory. Here's a scientific report that was put out by Nature, very prestigious journal, and they had the same question. How do we know it's not temperature? How do we know it's not humidity? How do we know it's not vitamin D? So they did a study looking at the countries of Europe, and this paper was titled Autumn COVID-19 Surge Dates in Europe Correlated to Latitudes, and not to temperature or humidity, pointing to vitamin D as a contributing factor. They looked at these countries in Europe, and all of these countries had surges in COVID-19 during the winter of 2020. They published this in 2021, and this is what they showed. There was absolutely no correlation with temperature in terms of which country had their surge first. There was no correlation with humidity as to which country had their surge first. However, there was with latitude, and you can see here that it started with Finland and ended with Greece. For anyone that knows geography will know that Finland is way up in the north, which means that as the sun is starting to come down during the winter months, it's Finland that's going to hit that critical time period where it's not getting enough sun to make enough whatever, vitamin D maybe. And finally, Greece is going to be the last one because, of course, it's the most southern European nation, or one of the most southern European nations. You can see here, Spain was there, a couple of others, as you can see here, whereas Sweden, Finland, Russia, Great Britain, these are all towards the north, and it worked out almost perfectly here in terms of a correlation. So we've established that it's some product of the sun that seems to be giving us these surges in COVID-19, not temperature, not humidity. But wait, there's more. So this was a paper that was published in the British Journal of Dermatology by a group out of the University of Edinburgh. And this is what they did. Very interesting study. They first looked at the United States, and they said, what is it about sunlight that is causing this to happen? Why is there a predilection for this to happen? And so what they did was they looked at the United States in the winter time, But because the United States covers a significant portion into the southern latitudes, they actually eliminated a bunch of the United States where someone could get enough vitamin D from sunlight. And they just looked at areas where there was no way they could make enough vitamin D in the wintertime. So they, in other words, excluded any sort of cause coming from vitamin D. And this is what they noticed. The more sunlight somebody got, the lower the COVID-19 deaths were per million. In other words, it went down. Now, what they used here, what the 600, 700, and 800 is simply the amount of ultraviolet A radiation. Ultraviolet A radiation is just a surrogate for sunlight. Vitamin D is not made from ultraviolet A, it's made from ultraviolet B. So this light could not be making any sort of vitamin D. They prospectively looked at it in England, and they found exactly the same relationship. The more latitude, the more sunlight they were getting, the lower the incidence of COVID-19 in terms of deaths. And then they looked at Italy. Again, exactly the same relationship. In conclusion, this study is observational, and therefore any causal interpretation needs to be taken with caution. However, if the relationship identified proves to be causal, it suggests that optimizing sun exposure may be a possible public health intervention. Given the fact that it appears independent of the vitamin D pathway, it suggests possible new COVID-19 therapies. And of course, this is so obvious. Here's the problem that we have in medicine and in science. We find some natural phenomenon that improves health, and then we try to extract the chemical or the thing inside of that natural thing, in this case, the sun making vitamin D, so that we can package it, so that we can copyright it, market it, and give it as a pill to make you better. How do we know that it's not the best it's ever going to be already packaged the way it is? And that's the thing that's so frustrating, is when you understand the solar radiation spectrum, only one aspect of light is coming from ultraviolet radiation, and that's vitamin D. There is a whole nother section of light, which is the visible light, which affects us in the circadian rhythm. It can also affect our brain and improve our mood. Who knows what else it's doing? And then, of course, the infrared light. The near infrared goes from about 760 to about 1400. So we're talking about this area here. As we'll show you, it's proposed by a number of authors to be the genesis of intracellular melatonin, which is a very, very powerful antioxidant. An example that I love to give of this is when they noticed that lung cancer patients that had higher vitamin E levels and beta-carotene seemed to do better when they studied them retrospectively. So what did they do? They extracted vitamin E and beta-carotene, and they fed it to lung cancer patients in a randomized placebo-controlled trial. What did they find? They found that those that were given beta-carotene and vitamin E were actually worse off in terms of mortality. The lesson here is sometimes these things that we find in nature are better packaged the way they are in nature. That is the question here at this point. So let's see why this might be the case. This is only a hypothesis at this point, but let's solid this up a bit. So this is from an article that was published by Scott Zimmerman and Russell Ryder. It has now been shown that the mitochondria produce melatonin in many cells in quantities which are orders of magnitude higher than that produced in the pineal gland. This subcellular melatonin does not necessarily fluctuate with our circadian clock or release into the circulation system, but instead has been proposed to be consumed locally in response to the free radical density within each cell, in particular in response to near-infrared exposure. In other words, mitochondria, which is exactly where the issues of reactive oxygen species, oxidative stress, is occurring in the cells, and where COVID-19 is playing a role. This is exactly where we need to have an antioxidant powerfully mopping up these chemicals that are causing mitochondrial dysfunction. And as it turns out, the majority of them are being produced in the mitochondria itself. The paper goes on. Based on an optical and biological review of the literature, it is proposed that the near-infrared portion of natural sunlight stimulates an excess of antioxidants in each of our healthy cells, and that the cumulative effect of this antioxidant reservoir is to enhance the body's ability to rapidly and locally deal with changing conditions throughout the day. In this approach, the role of circulatory melatonin produced by the pineal gland is to provide an efficient method of delivering supplemental melatonin during periods of low cellular activity and solar stimulus to damaged or aging cells in both diurnal and nocturnal animals, while circulatory melatonin may be the hormone of darkness. This is what happens during the night. Subcellular melatonin may be the hormone of daylight. And if you notice again, here's our solar spectrum. The majority of the energy coming from the sun is in the infrared portion. This is near infrared, and this can penetrate deep into the dermis and actually cause the production of melatonin, it's proposed. So what is it that's going on here? Why is this so important in COVID-19? What does the mitochondria have with COVID-19? Well, remember that in the cells, and particularly in the endothelial cells, what you have are these angiotensin II molecules, which are pro-oxidants, being converted into angiotensin 1,7 molecules, which are antioxidants. If you want your cells to be protected, you want as many antioxidants as possible, because pro-oxidants are damaging your cells, and damaged cells are cells that COVID-19 can take advantage of. Well, as it turns out, this conversion of a pro-oxidant into an antioxidant is occurring by ACE2. Now, ACE2 should sound familiar to you because ACE2 is the receptor for the SARS-CoV-2 virus. And this is important to understand because ACE2 plays a very important role in the oxidative balance of the cell. Because angiotensin II is a pro-oxidant, it's going to increase reactive oxygen species in the cell. These reactive oxygen species are what damages the cell. On the other hand, ACE2 increases the number of molecules of angiotensin 1,7, and this puts the brakes on reactive oxygen species, so that's good. Problem is when you get infected with SARS-CoV-2. When you get infected with SARS-CoV-2, it breaks down and blocks ACE2, preventing it from doing this conversion, and so that increases reactive oxygen species, and of course the virus itself attracts white blood cells, and that's going to also increase reactive oxygen species. So what you have here is a triple threat to increasing reactive oxygen species when you get infected with SARS-CoV-2. And unless you are having good balance of antioxidation in your cells, you're going to be affected negatively by an infection with SARS-CoV-2. And when this happens, these cells become damaged. And if these cells are damaged in the endothelium, they're going to cause clots to occur. And as that happens, you're going to have blood clots and hypoxemia. And this is what leads to the severity of COVID-19. So what is it that we can do to reduce reactive oxygen species? Well, at night, the pineal gland makes melatonin, which then goes into the cells, into the mitochondria, and mops up these reactive oxygen species. So unless you're looking at bright light at night, reading your smartphone or your computer, you're going to be then secreting melatonin if you're not doing that, and you're going to have a reduction in reactive oxygen species. This is why sleep is so important. But during the day, you're going to have sunshine, and specifically near-infrared radiation making melatonin. And that is going to help a tremendous amount in terms of reducing reactive oxygen species. So, is there evidence of this going on? The answer is yes. This is a paper that was published in December of 2021. They looked at 60 patients admitted to the hospital, and they measured 3 things. Number 1, they measured reduced glutathione, which is the amount of antioxidants in the cell. That's rGSH. They measured TBARS, which is a marker of oxidative stress in the cell. And they measured something called F2 isoprostane, which is a marker of oxidative damage. They found that in the control subjects in blue, as you got older, guess what happens to reduced glutathione? It goes down. So in other words, the amount of antioxidants in your cells as you get older goes down. Maybe this is the reason why that older people are more susceptible to COVID-19. Those people with COVID had a further reduction at their given age in terms of the amount of reduced glutathione. Now, you should understand here that melatonin actually can upregulate glutathione. Let me say that again. Melatonin, which is even more powerful than vitamin E, can upregulate the glutathione system. Let's look at plasma TBARS, which is a measure of oxidative stress. So the higher, the worse. Let's again look at our control subjects. As we go from younger to older, the amount of oxidative stress goes up, as you can see. But those with COVID at every age group had increased levels. Again, consistent with what we've been talking about. Once again, let's look at plasma F2 isoprostane, which is a measure of oxidative damage. Again, in our control subjects, we get older, the amount of oxidative damage goes up. But at every level, those who had COVID, it was higher at every age group. Based on this, it would seem to me as though one potential treatment for COVID-19 would be to get some outside exposure. Now, near-infrared radiation can penetrate through clothes. It bounces off of leaves and grass very well, and you can get quite a bit of near-infrared radiation from the sun without actually being directly in the sun. However, 100 years ago, people noticed that there was a lot of benefits to be obtained from the sun, because being in the sun not only gives you vitamin D, it also gives you near-infrared radiation, and it also helps with mood and your circadian rhythm, as we've talked about in the past here. We're getting a whole package deal when we go to the sun and we go outside, as opposed to just vitamin D. It seems to me that people many years ago seemed to depend more heavily on their observational skills. And observationally, a notable health reformer from the 1800s said this: "The feeble one should press out into the sunshine as earnestly and naturally as do the shaded plants and vines. The pale and sickly grain blade that has struggled up out of the cold of early spring puts out the natural and healthy deep green after enjoying for a few days the health and life-giving rays of the sun. Go out into the light and warmth of the glorious sun, you pale and sickly ones, and share with vegetation its life-giving, health-dealing power." She also wrote to her secretary this bit of advice: "Make it a habit not to sit up after 9 o'clock. Every light should be extinguished. This turning night into day is a wretched, health-destroying habit." What's interesting to me is since that time in the 1800s, we can see here that the amount of near-infrared radiation that we have been getting as a human species has been on a very precipitous decline, even to present day where we spend only 7% of the time outdoors. We have light bulbs that do not emit any near-infrared light, and we have low E-glass windows which do not permit any near-infrared light inside either. As you can see here, with the solar spectrum here in orange, we have a very wide distribution, as we have mentioned, of the solar spectrum. However, whereas before we had incandescent light bulbs that gave us quite a bit of near-infrared radiation, now today, as we see here with LED bulbs, almost 100% of the light-emitting energy that we get from LED bulbs is purely and only in the visible field and not in near-infrared spectrum. In terms of glass that we're getting outside, all types of glass are, of course, very easily able to allow visible spectrum to go through. But as you can see here, with clear glass from the 1950s and 60s and perhaps 70s, no problem in transmitting all of the near-infrared radiation that we're seeing here in this red envelope. However, high solar gain, low E glass is reduced. Moderate solar gain, low E glass is reduced even more. And now, with low solar gain, low E glass, almost no near-infrared radiation is coming through the windows. And there's a reason for this and also the light bulbs, and that is to save on energy costs for the building. Not necessarily having our health in mind, but saving energy on air conditioning. So I think all of this information clearly explains why we have this vitamin D paradox in COVID-19. And what I would like to see is that we need to start doing randomized controlled trials on sunshine exposure. In other words, people going outside. They don't necessarily need to be directly in the sun because near-infrared radiation can penetrate through clothes and it's easily reflected off of leaves and trees. There's a lot more to talk about this subject, and I highly recommend watching our Light as Medicine video. Vitamin D is not enough. I think everybody needs to understand this information. And for more information on EKG, ultrasonography, and other courses for continuing medical education, visit us at medcram.com. Thanks for joining us.